Welcome back, everybody. Thank you for the prompt return. I've been told off in the past we've been too much of a stickler for timing, but 5 minutes here and there doesn't half add up at the end of the day, and it's a long day with a lot of content. So I'm keen we keep things moving. So as I said, there's a slight change of tack for this afternoon, where I think we move more into the patient experience, family experience space. It's a special interest, certainly, to our team at Brain Trust, where we're here to offer a support service around the clock and making sure people are feeling on top of things and in control once they're back home after they've seen Stuart or their oncologist. We'll be kicking the afternoon off with a talk from Jo Fen Liu, who works at the Children's Brain Tumour Research Centre in Nottingham. She's going to be talking about predicting the risk of post-operative cerebellar mutism syndrome, which is an all too common problem for families who face a brain tumour diagnosis. So I'll hand over to Jo Fen now, who will be talking to us for the next 20 minutes. Thank you.
Thank you very much. Okay, first of all, thank you very much for giving me the opportunity. My name is Jo Fen Liu. My background is epidemiology. I've been working with Professor Walker here at the Children's Brain Tumour Research Centre on this cerebellar mutism project, which we hope to develop a stratified tools to identify patients at higher risk of developing CMS after surgery. So I'm not a clinician. I will try to come in from a slightly different angle to share our experience and some of the recent developments. First of all, myself and all the workshop participants here, some of the results I'm going to present, we have no conflict of interest to declare. Oops. Sorry. Okay. Posterior fossa tumors are the commonest primary intracranial tumors in children. Most of them, about 2/3 of the pediatric brain tumors that occurs at the site. After surgery, depends on what literature or what numbers you quote, we're looking at about up to 1/3 of the patients will develop mutism or loss of speech. There's a latency period between 2 to 7 days. The duration can last from a few days or a few months. Eventually, the speech will return, but unfortunately, they never go back to normal. There are lots of research in this field, and from how best to define it, how best to measure the severity, look at the risk factors, how best to treat or to support patients. And in Nottingham, especially in the project I worked on, was specifically interested to develop a simple imaging-based pre-operative risk assessment tool. We try to identify and separate the patients at low, intermediate, or high risk of developing the surgical complications. We hope that this risk assessment tool will inform the surgical consent procedure and enhance the decision making. So I'm not going to show you a short video, because I'm not going to talk a lot about anatomy or hypothesis mechanism. So I'm going to come in from a slightly different angle, listen to how the CMS, this condition, impact on patients, their families, and a few words from our research team members, see how they feel about
changed hugely, and there's very much an adjustment and a grieving process and a loss for those families to go through. And it's important how information is delivered, because in anxiety-provoking, stressful situations, for example, prior to a surgery of a parent's child, it's very difficult to take on board information.
You do exactly the same operation to an adult and to a child, and the adult will not get the same kind of deficits afterwards that a child does.
I could do hula hooping and stuff like that.
You can't do that. What, skipping? Skip, couldn't you?
Yeah,
And run.
yeah.
You can't really run anymore. You
No.
can't falling over. I think one of the things that we need to do is to keep undertaking research and keep gathering information. Some of my colleagues here at Nottingham University have been undertaking some research to identify the factors which place our young people most at risk of developing posterior fossa syndrome.
What we've been doing here in Nottingham is trying to go one step back from there, and we've asked the question, can you identify children who are at risk of developing the condition, or who are at particularly high risk of developing the condition, before they have their operation? Because if we can identify those children, it's possible that we may be able to change the way they're treated to reduce the risk of mutism as much as possible.
It's not that you come to terms with it. I think you just learn to manage the situation.
And the MRI scan allows us to look in detail at where the tumour is and what structures in the brain the tumour is involving. And so the idea we had was to look at all the scans of a large group of children who've had tumours in the cerebellum removed in the past, and to look at the features on the scan and see if we can use any of the features from the scan to tell us whether they were at particular risk of developing mutism.
And get better, you're not the same.
Tool to separate those low risk and high risk patients. And so the next step, the next question we should ask ourselves is, what's the literature evidence and what data do we need to collect? I think Rob Deneen, our radiologist, mentioned it briefly in the videos. Currently, I mean, this is a systematic review published in 2014. You can see a long list of risk factors being discussed or published, but the only thing that constantly showing the effect was tumor location and certain type of tumor, that's medulloblastoma here, and the invading brainstem. So instead, so on top of these confirmed risk factors, we expanded our search, go through different hypotheses. So we put together a much longer list. So these are the things we worked with our collaborators in Alderhead Hospital in Liverpool. So we put together 89 patients who underwent surgery and reviewed their scans and their clinical notes and put together those information that includes the non-imaging features, that's age and gender, primary tumor location, some non-anatomical features like tumor type. And also we've put more weight on this thing, that's the anatomical features. That means that whether the tumors invaded or compressed into these structures. I think the problem is the complexity comes in because tumor location and tumor type are highly correlated. And sometimes you have a tumor arise from certain location more likely to affect or invade into nearby structures. And so I think it is not the best, to look at them individually is not the best strategy. You really need to put them together and construct a model if you want to separate the low risk from high risk patients. That's one thing. And the other thing is we are going to develop a risk stratification tool for clinicians. So we need to speak to clinicians. We spoke to clinicians, see what sort of models they want. There are various ways to develop it. And the conventional ways in which we compare the case with non-cases, compare their profiles, see whether tumors at this site or with certain features are more likely to develop it. That's one way of doing that. And we can, based on literature, say there was a hypothesis or there's a pathways behind this. That could be another way. And more recently, people start to use machine learning or the data-driven approach. That means given no assumption, we push everything through the computer and let the computers find out what's the best predictive model. They both have strengths and limitations, especially for machine learning. It may come up with a model that can predict the outcome very well, but clinically doesn't make sense. Because they're looking for a pattern, an association, not necessarily a causal mechanism. So I think we spoke to the clinician. They would prefer to have something with something converted into a risk factor, so a checklist that can tick. And they would prefer something that clinically makes sense, so they will buy in. If we want to roll it out and promote it, the clinical community will feel more comfortable with it. So the way we structured the model is we started a very long list, as I've shown this out, over 20 variables. We use different techniques, the conventional way and the machine learning way, to shortlist them down to about 10. Then we push it through logistic regression. That's the standard way we use for structuring the prediction model. So we published our preliminary model based on the 89 patients from 2 centers earlier this year. So these are the these are the variables, the predictors we selected. So you can see this mainly primary tumor location and whether the tumors invaded or compressed into nearby structures and the age is there. In that model, based on the 89 patients, we felt that we have about the accuracy is about 88%, and we felt that we managed to pull them into low, intermediate, and high risk. And for high risk, we're looking at greater than 50%, where the clinicians feel it's more likely to happen than not. So that's the cutoff we chose. But again, this is based on 2 centers, so naturally the next step is we want to further assess or evaluate this model in a multi-center setting, see if this thing still applies when we roll out. Okay, so we organized a CMS workshop last year and invited 11 centers from North American and some European countries, and these are the list of centers who took part in the workshop. We asked all centers to submit the most recent 30 posterior fossa cases, including their CMS outcome, and submit this pre-operative scan set. We also asked centers to provide a surgical statement because different centers may have different equipment, different facilities, different ways they want to conduct their surgical procedures. So that is part of the workshop discussion. So this is just a short list of all the inclusion and exclusion criteria. So during the workshop, this is our radiologist, Dr. Rob Deneen. We have an intense discussion to communicate with the centers, the radiologists and the surgeons, how we want to define these imaging features. What do we mean by invaded or compressed? And how do we code these variables in greater details. And after that, we form a small groups. So you will have oncologists, surgeons, and radiologists. This is similar to the MDT settings in day in and day out. They make a group decision, they review it together. So we collect all the information. We ask them to review 30 cases, their own 30 cases during the workshop. So this is the cohort we put together. The first thing that struck me is the CMS rate is much lower than what I expected, because from the first set, that based on the 2 center, we're looking at about 30%, which is similar to literature reported or what the parents just quoted. And in this set, CMS rate is much lower, we're looking at about 16%. But if you look at the risk factors, I think there's nothing surprising. Certain histology tumor types or MRI suspected tumor type, that's before the surgery because you don't get histology report till after the surgery. So based on imaging, they can predict. The radiologist would say, we feel this is more likely to be ependymoma, medulloblastoma, or polycystic astrocytoma. We also asked them to identify the primary tumor location. Two things I wanted to point out. Medulloblastoma historically been reported many times one of the confirmed risk factors, but it's not so about ependymoma. So in this cohort, and the same as the previous cohort, we see an increased risk for ependymoma patients. And we feel it's probably because it's less common. So if you base on a single center or very small population, you don't see it. Okay, and secondly is tumor arises from cerebellar hemisphere. So you can see no patients develop CMS in this group. And this is the second time we see the same pattern. The previous set, we have 33 patients, and none of them developed CMS either. I know it's reported in the literature very incomplete, but we certainly didn't see anything within the 100 cases we go through in 2 cohorts. One thing we set out to do, because the literature review told us that one of the big problems is we don't have large-scale studies. So this is one of the bigger collections we can have, and we can certainly see there's a huge center variation, so I removed the center label. But you can see the range from 8% up to about 20%. That's a huge difference. But we need to ask ourselves whether this is a true association. Sometimes it could be down to it's really good, they manage the risk very well. Or it could well be the case makeup. And certainly in this country, we take all comers, we have catchment areas, but some countries, especially in North America, they will have a slightly different system. Sometimes they will self-sponsor and travel to a different centers, ask for surgery. That means patient defaults need to be healthier or fitter to travel that long distance to that centers. That could be part of it. And by only comparing the crude CMS rate, we won't see it. So that's something we need to bear in mind when we review the literature. Okay, then we recoded all our imaging data into binary and tried to see how well our predictive model works. First of all, if we look at the cutoff, it's roughly about 1/3 for low, intermediate, and high risk. So we seem to think have a very, visually, I think you can have 3 groups. It's very low risk, and something around here, and much higher risk, slightly higher risk at the plot here. Unfortunately, we didn't see that over 50%, which we expected to see. And I will talk about a few reasons we think it would be. But the thing is, if we can pull out the low risk, rather than identify the super high risk, if we can pull out the low risk group, we reinforce the surgeon's confidence in those established surgical approach when we go for, aim for complete resection. And as patients, your risk is no longer what's quoted as 1 in 3. If you have such low-risk tumor type, you actually have very small chance of developing CMS after surgery. And that will help, we think, in terms of taking consent. Okay, there's some issues when we try to upgrade from the experience based on 2 centers down to 11 centers. One thing we need to really think about is the inter-observer agreement. Because we asked the radiologist to sit down and review the scans. And some structures, especially the deeper, smaller structures, if we base on a piece of paper or a definition or even a short presentation, you may have different views than I do. So the way to tackle it, some of the cases must be probably, I can't say that for sure, there might be misclassification. So they were put down to this end rather than that end. So I think inter-observer agreement is something we certainly need to focus on if we want to roll it out at multi-center level. There are various ways to improve it. We can develop an online education modules, train them, and test them before they actually go out to code the variables. And we can perhaps, at data collection level, use visual aid to say, is what you're seeing now closer to this one, or this one? That will help them to put them into the right category. At least they're trying to code in a more consistent way. Or we can certainly go out and talk to people and communicate better in this way with our presentations. And the other thing I want to point out is for this patient falls into this and intermediate and high risk group, what we're interested in or the focus shouldn't be how accurate we can predict the outcome. Because these are pre-operative risk. It will certainly interact with surgical intervention. And our ultimate aim is to reduce CMS risk. So if there is interaction, we really need to look into it. And do we have a scope? I mean, there's a potential to look into it. Yes, we do, I think. Again, this is all the high-risk patients that's on the right-hand side. If you break it down by center, you can see there's actually a gradient. You have centers who manage it probably quite well, after 22%, that's about 1 in 5, and centers at higher risk, about 50%. So we can certainly learn from the winners what equipment they use, what technique they use. I think it's up to the surgeons or the clinical community to discuss and trial and learn from each other. But unless we have international comparison and big collection, we won't be able to do it. Okay, the other thing is probably some of you have already spotted. We have 3 centers here who have no CMS cases. But if you also look at the numbers of high-risk patients they have, you can see they're very different from the others. On average, you have about 1/3 of the patients fall into the high-risk group, while this center only have 2 to 4. So that kind of reflects what I said before. It could have something to do with the case makeup of their centers, or they could be really well, they could be managing the risk very well. We don't know. We don't have enough sample size for just 2 or 4 to make any firm conclusion. But certainly there's something there. And this is the other thing we talk about, the inter-observer agreements. There are a few things we can do. So if you look at the tumor sites, certain sites are things that are okay with certain sites, but radiologists struggle with deeper, smaller structures. And that's the thing we need to improve our agreement if we want to roll it out at a different level. So we thought we certainly need to revise our CMS risk assessment tool because we didn't achieve that 50% or above risk that we wanted to say. So we set out, and we repeat the analysis following the same approach, but this time we use our much bigger, 245 cases to model that. We follow the same approach. We use both data mining and the conventional check on the statistical significance to shortlist our variables. If there's anything mentioned in the literature that we feel we need to select, we will push it in. But more importantly, this time we add in additional conditions, which we need to achieve reasonable inter-observer agreement. So to ensure that we have a more reliable model, even if that means we need to drop some of the variables and replace it with something else. Because if we can't measure it reliably, there's not much point. Okay, so I'm not going to talk about the final model. We have a few candidates. We go through various iterations, and we think we can achieve about 84 or 85% of accuracy. We can still cluster into low, medium, high-risk group, but I think the next step is still far from we can roll out and call it a product to promote. I think we still need to evaluate at multi-center level again, and also more importantly to test it prospectively. And that's the other things we need to do. Sample size is always crucial. So we work closely with Posterior Fossa Society. Many of them actually are the workshop participants. And also we recruited through various sources. There are 22 centers across Europe, North America, and Middle East expressed their interests. Okay, so we feel that our preliminary model can confidently identify low-risk cases that will reinforce the surgeon's confidence to carry on with what they're doing. We still need to do a bit of work on the high-risk patients, see if we can push the high-risk group above that 50% threshold. I think the next steps is we want to develop a website training module, because if there's international centers, we can't go out and visit everybody or fly them in to organize a workshop anymore. I think internet is probably the best interface. We've already developed a prototype of training modules. We hope with additional fundings we can perhaps convert it to a website so that everybody can access it and use it. And more importantly, I think surgical techniques constantly evolve. So we need to continue this data collection, continue this international comparison, and learn from the winner. I think, as I said, the ultimate aim is really to reduce CMS rate, not to predict the risk, not just to predict the outcome. So if we can do anything to learn from the centers developing the new techniques to reduce the risk, that's what we want to do. Okay, so we can have gone this far without our lovely workshop participants. I think we're moving towards the right direction. They're all looking at, yep. So I think that's where we're at. I'm afraid I'm probably not the best person to take clinical questions. I'm sure Professor Walker down there will be happy to answer anything to do with the clinical application of this model. Yeah, thank you very much.
Thank you very much. It's really infusing to see work happening in a space where previously there has been nothing at all. At the same time, you know, I'm kind of in this camp where I just wish things would happen faster, but at the same time, they've got to be done right. So, you know, I think the rigour was what really came through there, and hopefully from this we can get to a really good place where we're, as you said, reducing the number of cases that are having to go through this experience. It's, you know, I know it's a big deal for the families that we're working with, particularly when it comes as a complete surprise, which I think Michelle's story highlighted. You know, it's when you're signing that consent form, it's just another little thing on the list, but when it happens, it's massive. So really important work. Next up, I'd like to introduce Emma Nicklin. Emma's come down from Leeds, like me. Hey. Emma is a PhD student at the Leeds Institute of Medical Research. She is focused on long-term issues and supportive care needs of adolescents and young adults who are brain tumour survivors, or essentially living with and beyond diagnosis. Again, it's a very little understood area, and I'm looking forward to understanding a lot more in 15 minutes' time.
Thank you. Hi everyone, as Will said, I'm Emma Nicklin. I'm a PhD student in my second year now at the University of Leeds, but I'm actually based at St James's Hospital within a research group there. And today I'm going to talk a little bit about some of the late effects that childhood brain tumour survivors experience, but I'm going to specifically focus on the late effects of teenage and young adults. So the experiences that they gain as they get older, so say take 5, 10, 15 years after treatment. So just to start with a little bit of background, I'm not going to go through it too much because there was quite a bit this morning. Brain tumours in children are significantly different to those in adulthood, so they differ in their incidence, treatment types, tumour types, and the overall survival rate is actually better for those in childhood, but because of their bodies and brains are still developing, treatment decisions can be difficult. And some children with malignant tumours will often require both radiation and chemotherapy, and such treatment, especially in very, very young children, can result in significant progressive long-term effects. And with the improvement of tumour treatment and survival rates, childhood brain tumours are now living longer, and many do make it, thankfully, to become teenagers and young adults. And therefore, it's so important to focus on the late effects of treatment and their survivorship experiences. And even though today my main focus is going to be actually on the late effects of survivors, we'll also discuss the experiences of caregivers, because having a brain tumour affects not only the survivor but those around them, and their informal caregivers support the survivors in the long term. So as I said earlier, I'm going to be focusing on specifically the late effects of the teenage and young adults, or TYA group. And this is the age group that I am focusing on in my PhD. And they're a very different survivorship group than those who are still children or older adults. As we all know, adolescence and young adulthood can be a very complex developmental time. We start to gain our self-identity, start new relationships, try to get a bit of independence. And this is why we think this is really important that this group are researched as an individual group, because these unique developmental milestones and life events are very different, as I said, to older or younger people. So to really get an idea of the late effects of this group, we conducted a systematic review. And a systematic review really allows us to collate all the published data and to summarise the findings. And other previous systematic reviews had looked at the late effects of children after treatment, or adults who were older, but none had actually looked at this teenage and young adult group. So what we wanted to answer or look at was, firstly, what are the late effects and issues of this group and their caregivers? Secondly, what are the supportive care needs of this group? And finally, are these supportive care needs actually being met at the moment? And with this review, we set the teenage and young adult age range at 14 to 39. And you might actually think that's quite a wide age range. But in the oncology literature, there is actually no set definition for what a teenager and young adult is. It ranges between countries and organisations. So we purposefully kept it fairly wide for this reason, to capture as much literature as possible. So what we actually found, once we'd searched all the relevant databases, we found 3,770 articles. And once these had been rigorously screened, we were left with 56 articles that published about late effects or supportive care needs. And of the included studies, just to give you a bit of an idea of the results to come, a bit of setting the scene. So over half was published after 2013, so in the last 5 years. And this isn't that surprising, because in the last decade, kind of quality of life research and supportive care needs has become more a priority in the research. Over half are published in the US. And the majority of studies reported quantitative data, so survey data. 10% was qualitative, so focus groups, interviews and things like that. And 14% included a bit of both, so mixed methods. And over half the studies reported data from mixed brain tumour samples, so they didn't look at just one brain tumour type, it was all primary brain tumours. And 29% of the papers actually reported brain tumour data with other cancer data, but reported brain tumour data separately, which is why they were included in the review. So, what did we find? If you remember, aim 1 was to look to identify survivor effects and issues, and we actually mapped the survivor issues onto this quality of life model. So the model's been adapted to illustrate the potential issues and late effects that TYA brain tumour survivors may encounter after they've had childhood brain tumour. And in the literature, social issues were the most commonly reported, with 34 articles reporting some form of social issue. So say such as issues with independence. For example, many of us growing up, getting your driving licence is kind of a key part, getting some independence from parents. But childhood brain tumours were less likely to drive than other cancer groups and other control groups. And then, say if we look at romantic relationships, if you have a brain tumour as an adult, you might already have cemented your relationships with friends, and you may even be married. But once you've had a brain tumour as a child, you might find it harder to meet someone and form a romantic relationship. And the literature revealed that young adults who've had a brain tumour are less likely to have romantic relationships when compared to other cancer survivors, and they're also less likely to get married. Then if we look at cognitive late effects, these were reported in 28 articles. The main cognitive issue reported was impaired memory, and the published findings established that impaired memory is a daily issue. Memory is essential in how survivors assess their ability to self-care and meet developmental milestones, such as living independently, making friendships and gaining educational achievements. And memory loss and other cognitive effects were actually described as an invisible effect. So unlike, say, physical effects, you can see them. Cognitive effects, they felt sometimes weren't as obvious and could go undetected. And therefore, sometimes this support may not always be offered because of this. Physical late effects were reported again in 28 articles. And so if we take issues with appearance, we know that when you become young adults, you tend to be a bit more conscious of how you look. And teenagers and young adults became more conscious of their physical effects of treatment, such as scarring, weight gain, small stature, and hair loss. So, and many parents actually reported that this could affect how their teenagers or their children could actually make friends with new people because they felt different to their peers. And psychological and spiritual issues were also reported, but not as frequently. So regarding psychological issues, teenage and young adult brain tumour survivors reported significantly poorer mental health when compared to other cancer survivors. Main issues included internalising problems and withdrawal. And then looking at spiritual issues, brain tumour survivors had significantly poorer optimism and self-esteem when compared to other cancer groups. But it's quite interesting that how different the views could be. So some survivors actually felt quite negative about their brain tumour, thinking that others viewed them very differently, but then other survivors actually thought that there'd been positive aspects. It had changed their outlook on life, it made them more mature, and they were trying to actually move beyond the illness. So what else did we find? So as you may have noticed, a lot of these late effects are rarely experienced in one capacity. They linked, and one thing can lead to another. So, for example, poor processing speeds could often affect how survivors could interact with other people, which made them feel isolated with fewer friends. Or survivors who are experiencing fatigue find it hard to gain employment because of the fatigue. And overall physical health problems could lead to the survivors not being able to take part in, say, sports in school or with their friends, and they felt it affected their overall social functioning. And in many studies, the late effects described were frequently more prevalent or intense than in other cancer groups, making it likely that brain tumour survivors will have a poor overall well-being. And this supports that brain tumour supportive care should be disease-specific and tailored to individual needs. And the second part of AIM 1, I'm not going to focus on it too much, as I said, but a quick overview, what was found from the caregiver literature. Firstly, there's a lot less data regarding caregiver issues, so only 9 articles reported any caregiver late effects. And we split these down into 5 themes. So starting with survivor well-being, while some caregivers had a kind of positive experience of caregiving, some were really worried about their child's or loved one's ability to succeed socially or academically, which kind of echoes some of the late effects that the survivors had. Uncertainty was a common theme, especially about their survivors' future health. So the threat of relapse was a common worry, and in some cases this actually stopped caregivers from planning into the future. But actually then in other cases caregivers looked more into the future because they were worried about who was going to look after the survivors as they grew older. Caregivers experienced increased responsibilities, doing tasks that for many teenagers isn't a part of doing, and so caregivers assisted survivors in organising their social interactions, trying to create new friendships, and managing medications. And caregivers also had less time to dedicate to maintaining their own self-well-being, feeling fatigued with reported social functioning, lack of reduced social functioning, and hindered careers. And finally, the pressure of keeping healthy family relationships whilst caring for a teenage survivor could prove to be challenging for caregivers. For some, their marriage had actually suffered, whilst others worried about their relationships with their survivors' siblings. So aim 2 and 3, if you remember, that was the supportive care needs and whether these needs are being met. And I'm addressing aims 2 and 3 together because there was very little literature or data on supportive care needs. So actually only 3 articles reported aim to report anything about survivor needs. But where reported, survivors said they valued social activities and support groups and just the ability, they just wanted to hang out more with people their age. Many survivors said that they needed more educational support, so more one-to-one time, more one-to-one help, and some extra time to complete assignments. And finally, some of the survivors felt that the long-term follow-up care that they received wasn't meeting all their needs. Problems described was feeling that they couldn't speak to the clinical team about their problems, feeling that the clinical team addressed their parents or their caregivers and didn't actually listen to them, and also feeling that the information they're given wasn't age appropriate for their current issues. Whilst caregivers felt, again, there was not enough support available for them or the survivor during teenage and young adulthood, caregivers felt that when their child was actually undergoing the treatment that they had a lot of support, but this support had declined as they moved further away from the treatment. And again, caregivers expressed that the following services would be most helpful, so parent support groups or caregiver support groups, specifically for caring for teenage and young adults, and also educational groups look for with age-specific information. And finally, there was no data regarding how and if current support services were used, so we still don't know how TYA survivors and their caregivers are using and benefiting from long-term aftercare and support from local and national charities. Because what we do know is that there are some great local and national charities that offer support to survivors and their caregivers, alongside the long-term follow-up teams. These are just a few examples. And actually, the Brain Tumour Charity does have a teenage and young adult service which has specific materials for this group. So they have a Facebook group just for teenagers. They do teenage-specific meetups, so with other teenagers. And they have an individual online telephone support. So what can we take from this systematic review? So there is gaps in the literature and areas for future research. So we found that there was many late effects that teenage and young adult brain tumour survivors could experience, but there was very little data focused on the needs of this group. Or unmet needs of this group. And despite that numerous studies had reported the late effects and issues, it's known that the presence of issues isn't always associated with the uptake of supportive services. So therefore, 3 areas of research are identified. Studies need to describe the needs and, more importantly, unmet needs of TYA childhood brain tumour survivors and their caregivers. Studies are also need to fully investigate TYA survivor and caregiver expectations and the values of supportive care needs. The value of supportive care services, and find out how and if these are currently being used. So more research is needed to understand what TYA survivors and their caregivers want and how they can benefit from this support. And these future research plans fit under many of the research priorities published by the NCRI and James Lind Alliance, The NSRI held a large survey asking patients and carers and healthcare professionals what they felt there needed to be more knowledge on. And from this data, they've identified 26 priorities for research that they thought would help people with and beyond cancer. And actually, supportive care needs and supportive service use was mentioned in 12 of these 26 priorities, which just shows how important getting the right supportive care is for patients and caregivers. So these are just a few of the 12 that focus on supportive care needs. So, all this being said, I'll move on to what I'm currently doing now. So from the results of this systematic review, I've designed a research project that has become the focus of my PhD, with the aim is to gain an in-depth understanding of the supportive care needs of TYA childhood brain tumour survivors and their caregivers. The specific objectives are to describe the met and unmet needs of this group, to explore if unmet needs differ between different survivors, so males and females, younger teenagers in comparison to older young adults, to determine whether these unmet needs are associated with quality of life. So this is kind of the so what question. So if we find out if someone has higher unmet needs, does this mean that it impacts on their quality of life? And finally, to explore the role and perceived use of support services for both TYA survivors and their caregivers. So I've actually just started data collection, and I've been collecting data from survivors and caregivers who are in the long-term follow-up team, using the long-term follow-up service in Leeds. And I've been asking them to do an online questionnaire to try identify their needs and unmet needs, and also a subgroup of this who have done the online questionnaires, asking them if they'll take part in an interview. Because questionnaire data is good for identifying, say, frequency of needs, but it doesn't always explain the why and why people feel and act as they do. So subsequent to these results, firstly, we can feed back to the support services and the long-term follow-up teams that currently provide support. And then, hopefully in the future, this evidence, and with other studies like this, we can help modify and develop support services to address both TYI survivor and caregiver unmet and desired supportive care needs. So I just want to say a quick thank you to my supervision team, and there's actually a paper that's in the process of being published about this systematic review, so that's coming out hopefully in the next few months, and a quick thank you to the funders. And I actually have a research advisory group which is made up of patients and caregivers, and they've been great at kind of directing the research and telling me what's important. So if there's anyone who feels that they'd like to take part in that, I'd be really happy to speak to them. And then thank you for listening. If anyone's got any questions?
Thank you. It's one in a million. There's lots to take in there, Emma. Thank you. I've got loads of questions, but I'm not going to ask them all. I'll just probably catch you at some point, or might ask a few at the end, after we've welcomed our next speaker, whose photo I don't have. So this is going to be interesting. Thank you. I wasn't sure which direction to look in. So this is another area where I think there's a lot of work to be done. We're sort of on the edge of this abyss, and the more you look into it, the bigger the challenge becomes. I don't know whether that's a fair summary or enough of a challenge for an introduction. But anyway, I'd like to welcome Louise Robinson to the stage to talk about her work on the impact of education following a brain tumour diagnosis.
Is that going to come up? Is it on here somewhere already, or do I need to put it in? I won't touch, I'll break it.
No.
Oh, looks like that one. I recognise the pink. Lovely, thank you very much. So my name is Louise Robinson, and I am the Click Sergeant Specialist Nurse Key Worker based in Nottingham, and I'm working with children from all over the East Midlands with brain and spinal tumours. And a massive part of that role is, as you would probably imagine, is looking at helping those children and young people either to get back into education or supporting them in education in the kind of longer term. So, what is the impact of having a brain tumour on education? Well, sadly, we do know that over 60% of children who are survivors of a brain tumour do go on to have some form of ongoing disability as a result of this. But that level of disability varies quite considerably. So there are some children that I've worked with who would come in for surgery, just have an operation for their tumour, maybe stay in hospital for less than a week, and then be back to school within sometimes a number of weeks, quite incredibly. And then at the other end of the spectrum, there are children or young people who would need much more extensive treatment. They might have a less smooth recovery from their surgery. We've already heard earlier on this afternoon about the impact of things like posterior fossa syndrome. And the treatment that these children are undergoing often too can impact on their recovery. So chemotherapy and radiotherapy can impact on the children in the longer term. So there was a really good piece of research done a couple of years ago by the Brain Tumour Charity in 2016 called Losing My Place, the reality of childhood with a brain tumour. And this looked at the impact on education. And in that piece of research, 90% of participants said that their education had been affected by their tumour or their treatment. And nearly 2/3 of them felt that they needed extra help in school because of that. But school in itself is a really excellent form of rehabilitation. When you think about school, really, it's work for children, isn't it? And any child in school is learning, they're developing, they're working on their physical abilities, they're working on their cognitive abilities. So actually that environment, once a child's had their treatment and they've been sent home from hospital, we've obviously done a lot of work with them while they've been in hospital. They might have had rehabilitation with our therapists as an inpatient. But once they get home, actually, school is a really excellent place for them to continue their recovery if they can get the right kind of support once they get into education. But returning to school can be quite an anxiety-provoking experience for both the child, the family, and for schools as well. Almost all of the schools that I've worked with have never supported a child with a brain tumour before I've gone in and met with them. It would be very unusual for them to have more than one pupil. So it's a new experience for them, and they don't always know where to begin with that. So supporting school is as important as supporting the family. And that's where the child's healthcare team come in. They can provide that vital role of providing information and linking within the health team to school to make sure that schools do really understand their needs in order to be able to meet them. So working with education. I should say that I'm not an expert at working with education. What I've learned doing this job, I've learned on the job really. There's one or two people in the room who've been along that journey with me. So it's been a learn as you go along experience. But these are some of the things that I found helpful. So an identified key worker is a really good starting point to provide that link for the family between health and education. And for somebody to work with the school and to advocate for that pupil. So that's really useful. That might be somebody like myself, it doesn't have to be. I also work with our local outreach nurses and with other professionals who can be that link person, but as long as school's got somebody that they can go to and the family's got somebody that they can go to that they know can support them. Sharing information is really important. Providing information about the different needs of the child, whether they're physical, cognitive or psychosocial, to enable the school to start that planning process. And when we're working with a pupil who has got quite complex needs, early meetings with schools are really helpful. Also liaising with special educational need teams can be really helpful to troubleshoot potential difficulties. Sometimes you might be working with a school that's really well prepared to welcome someone into the school who's got a new acquired disability. Some schools are very modern, very well adapted for children with all sorts of disabilities. Some schools are beautiful old buildings that are really, really lovely, but actually are not necessarily all that practical for helping somebody in a child who's maybe coming back to school in a wheelchair or something like that. So actually getting a feel early on for what the child's needs might be and how complex they're going to be, and how well the school is going to be able to respond to that based on their own particular situation as well, can be really helpful. So we always try and meet with schools or make contact with schools as early as possible to try and, like I say, troubleshoot that. It's also useful if we need to start looking at funding applications. These things can sometimes take time. So if we know that somebody's going to need quite a bit of support in school, the earlier we get the ball rolling with that, the better. Another thing just to say is this isn't a one-off thing. When I first started the job, I thought I would meet with the pupils. I thought I'd go into the school, I'd talk to the school, and that would be it, tick, job done. But it really isn't as simple as that. So this is an ongoing role, really. As we know, children change as they develop through childhood into adolescence, and their needs definitely change too, particularly when we're talking about their cognitive needs. So ongoing support is really important, and it's really helpful if both the family and the school know that they can come back to us if they're struggling, and we can do a little bit more work to try and help that child get the support they need. So, potential difficulties. I tend to split this up really into the physical, cognitive and psychosocial, but as Emma pointed out very nicely in her last slide, these things all link with each other, don't they? They don't sort of work in isolation, so something that impacts you physically is also going to have an impact on you psychosocially, for example. So we're going to just look at those in a little bit more detail now. This isn't meant to cover everything, it's just meant to give a feel for some of the difficulties that our children and young people can face. So mobility and fine motor difficulties are something we see quite a bit of, particularly when you've got children with things like posterior fossa syndrome. And acquired disability is something that is going to be difficult for schools to get their head around if a child's levels of ability is changing quite quickly in terms of their mobility and things like that. We also see communication difficulties sometimes, as has been mentioned earlier on. And visual problems is something that comes around actually really very often for children with brain tumours, and it's something that we monitor quite closely for all of our patients. So identifying those who have got visual difficulties and making sure that schools are adhering to advice about how to support them in school is really, really important. A lot of our local authorities have got specialist teachers for visual impairment and also for hearing impairment that can provide advice on that. So identifying these pupils and making sure they're referred to the relevant team is really, really important. So just looking at some of the things that can be helpful for physical difficulties. Obviously, when we're working with an individual child, we will look at their specific needs and put in a plan that's unique to them. But actually, some of the things that we do are useful for a lot of our pupils and can be kind of applied for many of those children. So first and foremost, we'd seek advice from the involved therapists. We're really lucky in Nottingham that we've got a specialist team called the Brill team. They work with children with acquired brain injury and they see all our brain tumour patients. And they're available to provide advice not only to schools but also to therapists in the community around the specific support that our individual pupils might need. Also, there may be therapists in the community, and like I say, those specialist teams as well for visual impairment, hearing impairment, that sort of thing. So involving them as early as possible and making sure school are in contact with them and are getting advice from the appropriate people is really helpful. Part and parcel in that is an early assessment of the school environment, particularly for children who've got physical difficulties. Like I say, some schools are beautiful and modern and have accessible areas and accessible facilities, but not all do. We've got some lovely, beautiful old schools as well, which are not so accessible. So getting it would be a community OT into the school to make an assessment of that school early on is really important if you think there's going to be difficulties, because it takes quite a long time to organise adaptations, particularly to be made in schools. If you need to adapt buildings and things like that, that takes quite a bit of work and planning and time to achieve that. And then there's just really simple things that can actually make a big difference. So it's not always the big things, is it? So just thinking about where that child is sitting in the classroom, how can you enhance that child's vision, hearing or communication just by where they're sat in the classroom can be really important. Thinking about how the pupil will get around school. So if somebody's in a wheelchair, obviously you're going to have to think about negotiating stairs and things like that. But actually, if you've got a pupil who's got difficulties with balance or is a little unsteady on their feet, equally that might be difficult for them, particularly if they're in a huge secondary school with hundreds of pupils flooding onto the corridors every time the bell goes. So thinking about, perhaps they can leave the class early, perhaps they can have a pass to go out if necessary. Those sort of things can be really helpful. And evacuation procedures is always something that needs to be looked at fairly early on as well, particularly if you've got to get somebody down from a second floor in a wheelchair when the fire alarm goes off. So things like that need to be looked at. Technology is being used more and more in schools now. And we're really fortunate that we're in a time where most children are used to using iPads and technology, and so that can be utilised really to help those children who have fine motor skills. So looking at how that can be utilised can be really helpful. And then also just making sure that the child's got a healthcare plan for any ongoing medical needs, and just so school feel confident about having the pupil back in. A lot of schools will worry about what happens if this child becomes unwell, what happened if this child falls over in the playground and bangs their head when they've had an operation on their brain a few weeks previously. So making sure that schools have got all that information and they know what to do and where to go if they've got any concerns is really important. That reassures school, and it also reassures the parents as well, which is really important for making sure it all goes smoothly. So just moving on to cognitive difficulties. I'm just going to touch on this really briefly. I'm not an expert in cognitive difficulties, but we do know that many of our children do go on to have some form of cognitive difficulty. Difficulties with processing speed is really, really common. So children might take longer to answer questions, might struggle to keep up in conversation during the classroom, or even actually at playtime, at break time when they're in conversation with their friends, they might struggle with those sorts of things. So processing speed can be an issue. As mentioned earlier, memory problems can also cause difficulties, and in itself that's going to impact on the child's ability to learn. Attention and concentration difficulties are common, and then later on in sort of the teenage years, difficulties with executive function come along, and that's part of the reason why it's really important to follow children throughout their childhood and support them throughout their education, because a child that's had a brain tumour as an infant, it's actually really difficult to know what their cognitive difficulties might be, because you're not going to expect a a 5-year-old to be able to do the same things that you're going to expect a teenager to be able to do. And executive skills are really those things that come online during adolescence, that help children to be able to plan and organise and those sorts of things. So sometimes difficulties can actually not really make themselves known until quite a number of years later. So that's why it's important that families know that they can get back in contact with us, schools can get back in contact with us if they are worried about the pupil. So helpful strategies, again, not very specific, just generic things that are really useful for a lot of pupils. A lot of pupils with brain tumours, but actually quite a lot of pupils without brain tumours as well. And quite often when we'll go into schools, we'll say, oh, you know, it might be useful to try A, B and C in school. We'll say, well, actually we do that anyway because it helps all of our pupils. So it's not complicated stuff, it's just stuff that is useful for many children. So breaking tasks down into steps, repeating things frequently, the use of handouts and diaries, anything that's going to reduce the cognitive load, so anything that's going to reduce how much the child's having to manipulate in their mind at one time, or reduce how much they're having to think about and remember. Like I said about memory, if a teacher can give them a nice little piece of paper that tells them the homework, they don't have to write it down as they're going along and think about that while they're also thinking about what they're trying to learn. Minimising distractions can be helpful, very difficult in a busy classroom usually. Using prompts and cues, so trying to look at using recognition memory rather than recall memory, which is easier for quite a lot of pupils. And above anything else really, I would just say allowing that extra time for the pupil to think and answer questions is really helpful. Okay, psychosocial. So with all those physical and cognitive difficulties that children are having to deal with, they're also having to deal with ongoing monitoring by the hospital, coming back to us every 6 months or a year for a scan, coming back into that environment where they've probably had quite a difficult experience previously. That can all impact on their psychosocial self. So things like low self-esteem, issues relating to changes in body image. Social isolation has been mentioned previously, but yeah, purely from being in hospital for a long period of time, and then that getting back into education can impact on that. And then sadly, anxiety, low mood and depression are something that we do see in quite a few of our patients. So what can we do to try and mitigate against that? So regular contact from classmates whilst pupils are off school is really helpful. Fortunately, we live in a world where social media is around us all the time, and most of our teenagers spend half their time like this on a phone, don't they? So communicating with your friends is actually a lot easier now than it was previously, but still it can be difficult. And when you're in hospital having treatment for a brain tumour, the gap between you and your friends, I think, can sometimes seem quite wide. So sometimes children and young people do find it quite hard to maintain that contact with their school friends. So encouraging that as much as possible, getting them to go into school if they're able, even if it's just for an hour or so, can be really helpful. Peer sessions can help. So sometimes we might go into a school and obviously only if the child or the young person wants us to do this. We would never do it without their consent. And talk to their classmates or talk to a group of friends. Okay, 2 minutes, talk fast. About the situation they've been in, to try and help them understand so they can support their peer more easily. Buddy systems can be helpful, and then just accessing those support mechanisms such as the pastoral care teams, more formal counselling, or advice and support from our psychology team at the hospital. Right, I'm going to start whizzing through now because I'm running out of time. Fatigue, but I can't not mention fatigue because this is a massive issue for lots and lots of children and young people who've been treated for a brain tumour. And I'm talking about not just physical fatigue, but also cognitive fatigue. So that tiredness of having to use your brain all day in school, or use your brain to communicate with your peers, and just keep that going all the time. So this is not something that's going to be cured by a good night's sleep. That said, a good sleep routine is going to be helpful, or rather a poor sleep routine is not going to help it. So what can help? Strategies such as pacing, planning regular rest breaks during the day, doing an activity just for a set amount of time and then knowing that you're going to have a break. Teachers and TAs working to help the pupils spot early signs of fatigue and taking a break before they get too tired. Sometimes a snack can help, and just that understanding and that acknowledgement that this isn't laziness. This pupil is really, really struggling to do something that the peers in the class are going to find a lot easier, so they are working really hard. Okay, school's responsibilities. So the SENCO is the person in school who's got the ultimate responsibility to ensure that any child identified with having a special educational need is supported. So that's the go-to person to start with. That said, sometimes other people can also be helpful. In a lot of secondary schools, you've got year heads who are working quite closely with the pupils, so they can be really useful. Schools are obliged to make reasonable adjustments to meet the needs of children with special educational needs and disabilities. So they can't say, no, we're not going to do that. They do need to make reasonable adjustments and in order to meet those children's needs. The local authority has got the responsibility to arrange suitable education for our children who wouldn't receive it otherwise. So those children that are going through, a year's worth of chemotherapy and are spending most of the time at home laying on the sofa or on the bed, they can be referred for home education, and that's something that the school can do, or it's something that our hospital school can do if necessary. And just a little note on resources. I suspect that resources in schools are going to get less and less and less based on what I'm hearing in the news. But schools are provided with resources to support pupils with special educational needs as part of their main budget. And on top of that, if there are children who have got specific disabilities or needs that can't be met from within that budget, they can apply for additional funding from their local authority. How this is done varies considerably depending on what county you live in, and it seems to vary from school to school sometimes as well, depending on how proactive the school is. So it can be difficult, but it is there. In some counties, you would need to apply for an education health care plan, which I'm just going to briefly touch on. So this is a legal document, basically, that defines the needs of a child with any special educational needs. If you felt your child needed one of these, you could make an application for one. Schools can make applications for them, and so can health professionals. However, I have to say, my experience is the most effective way is for it to go through a school and for all the information to be pulled in from all the different professionals working with the child, to make sure everything's in the initial application for that EHCP. Otherwise they just get turned down, and then you have to start over again and reapply. So that's something that can be done if a child's needs aren't met, or if the school feels that they can't access the funding that they need without it. They also they look beyond just the education side of things, so they look at clinical commissioning groups as well. So if your child needs things like physiotherapy, speech therapy, things like that, they can also form part of an EHCP. Right, so I'm going to summarise now. Just to say that education can and should form a key part of ongoing rehabilitation for children and young people with brain tumours. Offering ongoing support to the pupil, family and school facilitates the child's return to education, enhancing their recovery and optimising their ability to reach their future potential. And getting it right is really important. So, questions? No, there isn't any time. I'm just going to put up, there's some references there, and I'm just going to leave on the screen for a couple of minutes. There's some useful resources up there as well.
Thank you. Don't go anywhere. I just want to read out today's headlines.
Oh, no, don't.
For those that... No, because I think we've all got a job to do here. As parents, you know, I speak as a parent, and as charities. Click Sergeant, I know, are in the room. Ofsted condemns disjointed special educational needs provision, with thousands missing out on vital support. We know it's a tough climate, but I think it's the climate we've got. And I think we all have a job as clinicians, parents, as charities, to actually advocate on behalf of our children and to, you know, lobby hard. Every school we've spoken to wants to do the best they possibly can. They don't always know what to do, but there's a willingness. What worries me is the schools we don't hear from. And I think that's the big challenge here. I know that's something I'm going to be talking to Angus, I don't know where he's gone, from Click Sergeant about later, you know, with your strategy to make sure that every child that needs it gets the support they need. But I think this common sense that, frankly, you've presented isn't necessarily always common practice. And, you know, everyone here, I'm looking at Emma as well, you know, the work you're doing has a duty to sort of hammer this common sense home and make sure our children are being really well looked after. Because school is potentially a really good place for them to recover. Timings, we've drifted over. There was a break that was supposed to finish at 3. I think we do need a break. It's quite warm in here. Can I suggest we take some questions after the next session? Because they're all along a theme. We've got some work and some sort of talk around the caregiver perspective straight after this break. And then I suggest we take some questions around quality of life, experience. I'd love for some parents to share any tips they might have at the end, you know, make the most of us all being in the same room. So does that sound okay to everyone? Yep. Quick break now, back at, can't see the clock, 20 past. Thank you very much.